Feel like just another number at the doctor's office? Dr. Heather Saran gets it. She was tired of the grind when it comes to traditional healthcare, so she opened an office that provides a service called direct physician care.
I'm not contracted with insurance, so the patient pays me directly. There's no copays, there's no surprise bills.
No crowded waiting rooms, no rushed visits, just care without the insurance red tape.
Whether you have diabetes, thyroid issues, or need help with your hormones, Dr. Saran crafts a plan that's all about you.
We're talking with her about it on today's Direct Diabetes podcast. Dr. Saran, can you first tell us a little bit about your background and what inspired you to become an endocrinologist?
I, growing up, was always interested in healthcare. I wasn't sure exactly what I wanted to do with my life when I was in high school. So even, going to medical school, becoming a doctor was a little bit of a pivot. Originally, I went to school for nutrition. That was my passion. So when I did decide to go into medicine, endocrinology was a great fit because there's a lot of people who need help with nutrition, specifically if they have diabetes. And we don't get as much of training as we should in nutrition in medical school. So having that background kind of puts me above kind of your standard doctor who got, a 2-hour lecture on it in one day.
People might be familiar with concierge healthcare, but you provide something called direct primary care, which is similar to concierge care, but can be more affordable, and it's insurance free. Tell us how that works.
So part of this is probably just a matter of semantics and how you want to look at it. But the definition of a concierge practice would be a practice who still takes insurance, but they charge an annual membership just to be a patient there. But you're still paying, a copay. You may get a bill from your insurance. Whereas my practice would be considered direct care because I'm not contracted with insurance. So the patient pays me directly. There's no copays. There's no surprise bills. We have options depending on, what fits in someone's price point. So I do offer memberships where if you are at the highest tier, an elite member, then pretty much everything's included. There's no extra fees. That may not be in everyone's budget. For our premium members, they have access to me, but it's limited to one visit a month. That's more than most people need. But it just means, if you're asking questions about in between, that either counts as your visit or there may be an extra charge.
And what led you to, switch to this model rather than, the typical type of office that we're all used to?
So let me just say, again, in medical school, they don't teach us anything about business. So this was never plan A. I was really just there to, serve the patients, do my best as a doctor. But when it came time at my last practice to become partner, I realized there was a lot of economics, a lot of business decisions to be made. And being part of a partnership, not everything always went the direction that I wanted it to, or we were just really limited in what we were being reimbursed. And I was just told, see more patients, see more patients, see more patients. That was the only solution to get over the rising overhead. And no one was happy in that model. So, my patients may have felt rushed. I felt rushed. I'm late to my kids' dance classes. So with this model, I'm really able to provide the patients with the time that they want. The time is more structured where I'm not rushed. I'm not having to spend extra time, catching up on notes and visits. So all in all, everyone is happier in this model. My patients, me, and my family.
Yeah, that sounds great. Like it gives you more control, of the whole situation. Yeah, you're not having to answer to insurance companies and all their red tape. Yeah. And
patients love that they can get a hold of me. I have one assistant. She usually answers the phone, or she'll call you right back. A lot of people feel like they're kind of getting lost in this phone tree, press 1 for this, and then no one calls them back. Mm-hmm. So with this, even though it may not be me always answering the phone, it's always my assistant. And we're always make sure we get back to people in a timely manner.
It really is much more personalized care. It sounds like it's kind of like the old days, when you would go to a doctor and
Yes. No, it's getting back to the way things were. The unfortunate thing is that the reimbursement for doctors has either not changed or, Medicare payments have gone down the last 2 years in a row. I think we all know inflation and prices of things have gone up, and there's a big discrepancy. So the physicians are the ones carrying that burden of just see more patients, see more patients. And it can come off as, that we don't have time for you. And that's not our intention. It's just there's only so much time in a day.
Right. We're all human, right? And yeah, they're doing the best they can. So when it comes to somebody with diabetes, how does the care you're able to provide compared to if they go the traditional route to bigger offices?
So as you alluded to, it's much more personalized care. So I have the time to really get to know my patients. So especially if you're on insulin, my patients with type 1 diabetes, I learn what your schedule is. So I know what time you walk the dog. So, we're looking out for hypoglycemic events and what's happening, or your blood sugars were high for a couple days. And it's like, oh, that's right. You just got back from your trip to California. We're going to ignore those couple days. You were out, relaxed, having a good time. Didn't happen DK in the hospital. You did your best. We'll look at the rest of the data when it's more of real life. And patients are able to get a hold of me. So someone called me last weekend. It was a Saturday, but I answered the phone. Their blood sugars are normally pretty well controlled. They were seeing numbers in the 200s. And these aren't critical numbers. These aren't you have to go to the hospital numbers. But this patient had never seen that before. She was used to running in the 100s. So I was able to talk to her, give her some tips for she was sick, how to overcome getting those blood sugars down with sick day management. And in the long run, this kept her out of the hospital. Before, she's like, no one would have called me back on time. I was starting to panic. I would have ended up in the emergency room. And then you've lost your whole day and, you get a big bill at the end. So sometimes people think, oh, it costs more money to do this. But in the long run, if you're getting more individualized care, this is going to save you money when you can stay out of the hospital and save on all those bills.
You were talking about how you can see that they walk their dog and different things that they're doing throughout the day. I assume all of your patients then are using CGMs, continuous glucose monitors, and you're tapping into that data.
Most people are, some people aren't. Some people don't want to be reminded of what their blood sugars look like, all the time.
Okay.
Sometimes it's something we work for or we do a trial. I usually have samples of different brands in the office. So, try this for 2 weeks. If you hate it, at least now you know. So I don't require anyone to have a CGM or have a pump, but I mean, CGMs have really, really changed the way we manage diabetes. I remember I used to download meters all the time. That's more or less obsolete. People usually have one on them for an emergency, but yes, I'd say the majority of my patients are probably using, CGMs.
Do you find patients with access to more personalized care like this tend to have better A1Cs overall?
Overall, yes, definitely. A lot of the patients coming to me are already fairly invested in their healthcare. They're putting their dollar and their energy into making sure that they're on track. So I think there is a little bit of some selection bias. People are invested in their health, they're bought in, they want the best for themselves. Then we can really just kind of fine tune things. And sometimes I know patients so well and things are a little bit off and they're like, I was just having an off week. And it's like, okay, we don't have to change your settings. We can go back and look at the rest of it. And, I have time to go through that data and say, yeah, I think maybe we may have just caught you in an off period. And if things are back on track, I think especially people living with type 1 diabetes, they're in control. I'm not there with them all the time, so you really have to build that trust with someone. And it goes both ways. I trust them to have some autonomy in making some of those changes or no changes.
When it comes to the latest CGM technology, continuous glucose monitors, are you finding that even some of your non-diabetic patients are wanting to use those? They're kind of like a fad right now. People are really interested in watching their blood sugars, and what are your thoughts on that?
Yeah, I think it can be a great tool for a lot of people. Even some people where they may have pre-diabetes, but their insurance won't cover it because they don't have that code. So I don't take insurance. My patients still utilize their insurance for their supplies, their medication, their labs, things like that. So some people are really surprised wearing it. It can be really eye-opening to see like, oh, when I eat rice, my blood sugars, really go up and they stay up. That can be kind of eye-opening for people. I, every once in a while, will put, one of the sensors on just to kind of be reminded of what my patients go through with alarms and things like that and insights. And I learned if I eat grapes, my blood sugars go really high. They
Oh,
come back down, but they
huh.
definitely do spike. So I've learned some things, and these days there's some that are meant for people who are just doing it more for, fitness and nutrition, not necessarily, having to manage insulin where it's a little bit more simplified. One of the limitations for the CGMs that are meant for people with, diabetes or on insulin, is the ability to detect lows. And if people don't have insulin resistance, they don't have hypoglycemia, it's normal for, a young, healthy person to be sleeping and have a blood sugar of 55, 60. But they'll get alarms all night. So that can be rather annoying. So the latest over-the-counter ones from, two different competitors that I can think of off the top of my head. They've more or less limited those low alarms because it's not meant for people who are on insulin. But it still allows people insights to see when their blood sugar is rising, and may give them some tuned into whether it's a certain food, whether it's stress, it's an activity. So that can have people have a better sense of what's going on with their body and how they may need to adjust things.
You hear a lot of people are told that they have pre-diabetes. They're on the cusp of that. So, what role do diet, exercise, and stress management play, in your opinion, in reversing or controlling type 2 diabetes?
So it's interesting you bring that up. I remember talking to one of the physicians who's also in the Phoenix Valley area, and he was saying, he's been around for a while when they were making these diagnoses. How do you say you have diabetes? How do you say you have prediabetes? What's normal? It was kind of arbitrary cutoffs, but especially with rising obesity rates and things like that, there were more people who fell into the diabetes category if they would have put a cutoff of like a fasting glucose of 100. So they kind of created prediabetes because they didn't want everyone flooding the endocrinologist. There's not a lot of endocrinologists out there. But the underlying reason, the insulin resistance, when we're on our spectrum for type 2, are pretty much the same. So I think that's been an unappreciated, population. Um, so yes, people are amazed, oh, my sugars are up, especially if they're wearing one of these sensors. I took the dog for an extra long walk or I went for a jog, something like that, and they see their sugars come down. So exercise plays a big role, but I think there's a lot of people who, maybe their annual blood work, their fasting sugar is a little high, but it doesn't trigger alarms, for their primary care. There's so many things going on. And there's really not a lot of symptoms. People aren't going to feel much at that point. So prediabetes is generally silent. Sometimes people are shocked when it just kind of progresses, even if they do nothing different. Just with time, it can progress to diabetes. I'll have people come and say, I just found out I have diabetes, and I'm looking at their blood work from the last couple years, and they had diabetes the whole time, but no one took the time to sit down and give them that label and talk to them about what they need to do.
Hmm.
So I think that early intervention is really important. I think you hear a lot of chatter these days about longevity, and I think some of that is kind of just a rebrand of preventative care, of trying to, prevent things before they progress. So kind of the old adage we were taught as endocrinologists is, if sugars are high for a long time untreated, you can end up with all these different complications. But they can be prevented. So I think, especially in my practice, we really put a focus on that. And I do have a fair amount of people coming to me for prediabetes and looking for advice of, how can they reverse this? Or I have some people who are relatively thin, they don't fit the picture of that insulin resistance. And so then we're doing a deeper dive into, what could be going on. Could this be a type 1? Could this be a MODY? There's other things out there where it's not always black and white, type 1, type 2.
There's a lot of buzz around GLP-1 medications right now. What should people understand before starting those?
I think the main thing for people to understand is that what we're seeing in terms of side effects and benefits is we're seeing a lot more benefits come out these days. So these medicines have been around for a long time. They just weren't popular. I think as medicine has progressed, the original GLP-1 was a twice a day. That was cumbersome. Then they progressed to a once a day and then finally once a week. And even as the once a week medications evolved, we saw more and more weight loss. And that's really when the side effect, became the benefit. And now you can buy the same medicine under a different name just for weight loss. Um, but it's not for everyone. It's not a quick fix. So, I utilize them a fair amount. I'm a big proponent of them. But in my weight loss program, I require people meet with a dietitian. So they're really learning good habits. This isn't just a band-aid to suppress your appetite. This is, learning the tools that go along with it. So, if someone truly is, obese, and maybe they're trying to avoid bariatric surgery, then it's a great tool, but we look at it more as kind of a lifelong medicine, you know, drop some weight and then maintain it. There's a lot of people out there in popular culture who don't have much weight to lose, or they're just looking for an easy way out with some, appetite suppressant. And that's really not what it's indicated for, and I really want my patients to learn those, healthy habits. And some of it is psychological. It can be mindset into, what were you taught as a kid? Finish your plate. What did your mom say? You can't have dessert till you clean your room. Kind of unpacking some of that. And also just getting into, what's your focus, what's your goal? That's what I talk to people about. So sometimes people have a number on the scale, but what I hear from a lot of my patients is, they want more energy, what they could do, without this 20 pounds, keep up with their kids. And so sometimes there's not a number goal. It's just, okay, let's get you feeling better. Having fat tissue, adipose, it's really inflammatory. So sometimes it's not even just the number on the scale that's making people feel better, but getting rid of some of that inflammation. People have less joint pain, they have more energy, they can get back to really living their life.
When they go off of the GLP-1s, does the weight tend to come back on? You're helping them learn lifestyle changes, which will hopefully maintain that. But is that a big issue?
Right. So it can be for some people. Obesity is multifaceted. A lot of it's probably genetic, things that may be out of someone's control. Our hypothalamus has kind of a set point, where it thinks we should be in terms of how many calories we should be eating or weight. So for some people, it comes back right away. Some people, it creeps back. But I have a fair amount of people where they're able to get it off and keep it off as long as they keep up with those healthy habits. So that's why I don't love crash diets. I prefer more kind of the slow and steady, and that, gives your body some more time to kind of adjust, where it doesn't feel like such a crash where your body is trying to conserve.
Are you seeing any side effects? Like I've heard of hair loss. Are you seeing any side effects people should be aware of with those?
So hair loss, yes. A lot of what people talk about is the side effects of like Ozempic, are really the side effects of dramatic weight loss. So we see this a lot in bariatric medicine, bariatric surgery. People lose weight quickly, and we've never had medicines that were this effective before. Before, people were lucky if they lost 5% of their body weight, and we're seeing closer to 30% in sustained, whereas bariatric surgery is 30 to 50%. It's not as dramatic, but for some people it can be. So losing weight can be a stress on the body. So women have a baby, they lose their hair. You lose a lot of weight, you lose your hair. There's also things like gallstones. Again, weight loss, a lot of people are more prone to gallstones. So there is some correlation there, but it's hard to say that it's really a direct impact of the medicine, the molecule itself. So
Yeah.
I think the main thing is people will usually have an upset stomach in the beginning. So kind of getting used to that.
And then that goes away eventually, hopefully.
For most people, yes. Usually the first couple weeks, when they start it, or if we end up having to increase their dose, there may be a little bit of, gastrointestinal discomfort. The gut is literally slowing down. The food's not moving through as fast. So it's sitting there longer. People can get queasy. So I always counsel people to avoid eating, bigger meals, get used to having leftovers, and avoid those greasy foods that are really just going to sit there. And having a good bowel regimen, because people can be prone to constipation. So especially if people are already prone to that, it's good to work on kind of some natural remedies, and sometimes even people need some supplements to keep things moving along.
Okay. Well, outside of diabetes, what other conditions do you treat most often?
So I practice general endocrinology. My practice where I am now versus where I was before is still fairly similar. Weight loss has been a big, thing that a lot of people are looking for. So I enjoy doing that, especially with my nutrition background. But the bread and butter of endocrinology is diabetes and thyroid. So I treat overactive, underactive thyroid nodules, thyroid cancer. Some, less common conditions would be adrenal disorders, pituitary disorders, osteoporosis, low testosterone, PCOS. There's a lot. When people think about hormones, you say endocrinology, the translation is hormones. They think about reproductive hormones, and that's part of it, but that's a small part. No one's thinking about their parathyroid and how it's affecting their bones and, potential for osteoporosis and things like that. So there's a lot we do that kind of the layperson may not understand that it's a condition that even an endocrinologist would manage.
All right. Well, if somebody is interested in talking to you, what are the best ways they can reach out to you or learn more about you? Like, what are your socials and your website?
Yeah, so if you go to my website, it's just brightendocrinology.com, BRIGHT. You can link to my social, you can read about me, you can look at our services, pricing, and you can even book online. So we do have more availability than you can see online. If you call, if it looks like we don't have openings for a few weeks, we might, they just don't show up there. And you can also follow me at dr.heathersaran on Instagram. And my Facebook has my name in Bright Endocrinology if you search for that.
Okay, great. Well, thank you so much for doing this today. We appreciate it.
Yeah, thanks, Rebecca.
To hear more Direct Diabetes podcasts, visit directdiabetes.com. Please also subscribe, follow, and rate this podcast. It helps us a lot. Thanks.